Dr. Hershman is co-leader of the breast program at Columbia University and has developed an expertise in the areas of breast cancer survivorship, late effects of cancer therapy, health outcomes, health disparities research, and cancer clinical trials. She has received grants from the American Cancer Society, Department of Defense, the Susan G. Komen Foundation, the Breast Cancer Research Foundation, and the National Cancer Institute, as well as several clinical trials funded by the pharmaceutical industry. She is involved in clinical trials research on a local and national level, working with many national leaders in the field. She is co-chair of the Cancer Care Delivery Committee of the Southwest Oncology Group, where she is also on the Breast Cancer, Supportive Care, and Cancer Survivorship Committees. Dr. Hershman has a large clinical research program in breast cancer with collaboration linking clinical research, population-based research, and basic science research. Please join us in welcoming Dr. Hershman.
So today we're going to talk about clinical trials, and often patients with cancer are asked to participate in maybe a whole host of different types of clinical trials, and really that's how we move the field forward. We have learned more about cancer therapies and etiology from generous participants in clinical trials, but often people are asked to participate and don't really understand the fundamental questions that they're being asked when they're asked to participate. I'm not sure how to move this forward. Oh. So the first question is, what is a clinical trial? And a clinical trial is a way of looking at new ways to prevent, detect, control, or treat disease. The goal is to find if a new test or therapy is safe and effective. And in order for the results to apply to the population, it's very important that clinical trials include a wide variety of different types of people with various ages, various races and ethnicities and genders, so that ultimately we can make sure that we understand how the whole population may respond to a given treatment. In a clinical trial, participants are assigned to receive one or more interventions, and sometimes no intervention. Researchers evaluate the effects of an intervention on some type of health-related outcome. And the assignments are typically determined by the study protocol. Participants may receive a drug, a treatment, a procedure, or any other type of intervention when being asked to participate. And there are a variety of different types of clinical research categories. There are interventional trials, observational trials, ancillary trials, and correlative studies. And this is how the NCI defines each of the types of clinical research. An interventional study is where individuals are assigned to receive a specific intervention. The intervention can either be a drug, a device, or some other type of intervention like a behavioral intervention such as exercise or diet. The intent of the study can either be diagnostic to diagnose a new disease, it can be therapeutic in terms of treatment of the disease, and it can be supportive in terms of somehow taking care of a side effect or a consequence of a treatment. Assignments to a clinical trial or interventional trial may or may not be random. Occasionally, assignments can be determined between two different groups, in which case a patient can randomly be assigned to one treatment versus another, or one treatment versus no treatment. And ultimately, participants are followed and a certain health outcome is assessed, which has been predetermined. An observational study, on the other hand, involves no intervention or alteration of the status of a participant. Biomedical or health outcomes are assessed in a predefined group of participants, and those health outcomes may be similar to what you see in a clinical interventional trial. Participants may or may not receive the intervention, but ultimately in this type of a study, the investigator is not responsible for assigning who gets which intervention. And this is a graphic way of showing the difference between a randomized controlled trial and an observational trial. In a randomized controlled trial, the population of interest is screened. There are certain eligibility criteria that must be met in order for a patient to be able to participate, whether it's a certain disease they have, an age category, or whether or not they can't have certain diseases or be on certain medications. Ultimately, eligible subjects are approached, and if they agree to be part of a clinical trial by and agree to sign a consent, their treatment allocation or interventional allocation is assigned randomly to either intervention A or intervention B, and they're followed prospectively to evaluate whatever that outcome may be. Maybe it's disease-free survival. In an observational study, a large population is evaluated, and it's known that in the community when patients are treated, a variety of different factors may contribute to why somebody may get one treatment versus another. So all of those factors are ascertained. And ultimately in the analysis, the analysis is of people who got intervention A versus people who happen to get intervention B, and not necessarily randomly assigned. And the same type of outcome can be assessed. And ultimately the thought is that if you control for the patient factors, provider factors, and system factors that might have contributed to that assignment, you may be able to detect the difference between intervention A and intervention B without having to conduct a randomized trial. So there are some strengths of observational studies, and that they allow us to examine real-world populations. They're often more diverse, and it increases the generalizability of the findings. There are often large number of participants. They can leverage existing data, and it can include vulnerable populations that aren't typically allowed to participate in clinical trials. Because these studies can be much larger, they can allow dose-response relationships to be determined, and they can be completed quickly with a lot less cost than a prospective study. The limitations of an observational study I already mentioned. The first can be selection bias, and that comes when we give one group as opposed to another an intervention based on the characteristics of that group, and that can influence the outcome that we're looking at. And that can result in a systematic error in our ascertainment. We call that selection bias. And the way we get around selection bias is doing what I said before, which is to try in the analysis with sophisticated statistical techniques to control for all those other factors that may have influenced an individual's decision to get one treatment versus the other. Observational data can also be limited by what we call performance bias, and that's when you deliver one type of intervention, and then by doing that, the patient gets a better quality of care, and it's the better quality of care that may lead to the outcome of interest. So it's almost like an innocent bystander. And the third is what we call detection bias, whereas you may more easily see the outcome of interest, whether it be the diagnosis of cancer in one group rather than another, because of the way your detection is, and that can result in that group looking like they have a higher amount of disease. Ancillary studies are studies that are stimulated by a large clinical trial, but they answer a secondary question. And they often include patients that are accrued to a main study, but then ask them to participate in something else. An example may be patients that are recruited to a study of one of two different drugs where the outcome is survival, but the ancillary study is maybe to look at change in a blood biomarker or change in mammographic density. A correlative study is a laboratory-based study where specimens may already exist, and those specimens are used to determine risk outcomes and response in a way that wasn't dictated in the original protocol. So there are different types of clinical trials. Clinical trials can be diagnostic, in which case they're designed to evaluate interventions that are aimed at identifying a disease. They can be for prevention, where they're aimed at preventing the development of a disease. A screening trial, where they're designed to examine methods for identifying a condition or risk in people that don't already have the condition. Treatment, which we're often most familiar with, where the goal is to really determine whether or not one treatment works over another, or one treatment works over the current standard of care. Study can be supportive care in nature, in that it's used to maximize comfort, minimize side effects, or prevent the decline of a health condition. And a newer way of thinking about the last category is what we call healthcare delivery, where there are protocols that are designed to really evaluate how we deliver care, the processes involved, and the quality of the care that we give. So clinical trials, interventional studies usually progress in a certain order. And typically, especially when we're talking about drug treatments, often there's what we call preclinical evidence, where there's been a lot of work that may be based on the mechanism of the disease, where the drug is tested in culture, in tumor, in mice, in larger animals, and if a drug looks promising, the first step is to see whether or not it's safe in humans. And the first step in assessing human safety is with what we call a phase 1 study. And the purpose of a phase 1 study is to find the correct dose. Once that's been determined, then usually there's an expansion to what we call a phase 2 study, where many more patients are evaluated. They're not randomized. They're all usually given the drug. And the goal is to look at an intermediate step, like shrinkage of a tumor. And then ultimately, in order for a drug to get approved, often you do a randomized trial where you're comparing it to a standard, and you're looking at an efficacy endpoint that is meaningful, such as survival. So as I mentioned before, the preclinical stage is really testing in animals to determine if it's safe in humans. The phase 1 study is to see how safe it is and what the right dose is, and it usually involves 20 to 30 patients. Phase 2 studies can be quite large, 100 to 300 patients, and it's used to see whether or not the treatment is efficacious and safe. And as I said, phase 3 is to really show the effectiveness of it, to check for side effects, and really to compare it to something else, whether the comparison is another treatment or no treatment. These are often large and can involve 1,000 to 3,000 patients. If it's a disease like breast cancer, where women do very well and they're diagnosed with early stage disease, sometimes these studies involve 8,000 or 9,000 patients, followed for 5 or 7 or 10 years in order to get the right answer. There's also a phase 4 study, and a phase 4 study is when a treatment is approved by the FDA and it's available to the public, but you're still either monitoring the benefits and the risks, or you're using it for a different indication altogether. So a protocol is usually what's written by investigators to define the criteria of what's in the study. And a protocol typically defines who can participate, what the length of the study is, what intervention the patients will receive or not, and what information needs to be collected. And one of the most important components of a clinical protocol are the criteria which allow somebody to participate or not participate in that study. And the most common things that are included in cancer trials involve age, gender, type of disease, stage of disease, whether or not they've had prior treatments or not, what their other medical conditions or not that allow them to be able to participate. And we often have to balance wanting to include a large number of patients to be able to get the study done quicker and be able to make our results generalizable so that they apply to a large number of patients. But we also want to be safe and make sure that we find the answer that we want to find. And sometimes these two things can be at odds with each other, so that if you make the eligibility criteria too broad, you might see toxicities that hide an effect of the therapy, and if you make it too narrow, it may be hard to get the study done. So once a clinical protocol is written, it then has to become approved. And the way studies are reviewed in this country are through institutional review boards, which are really directed to make sure that people's ideas are safe and not putting patients at unnecessary harm. And in cancer, often there's more than one review. Many studies are done, are reviewed by the NCI through what we call the central IRB, and they are also reviewed at the institutional level, and sometimes there's a third level of review which is cancer specific in NCI designated cancer centers, where there's a protocol specific review committee just for cancer trials. And this is supposed to give an objective review of the protocol to make sure that patients' rights and safety are protected. So as I just said, the IRB is an independent committee, and it usually includes doctors, statisticians, community members, really to protect the human rights and ethics of the research that we do and make sure that whatever we ask patients to do is safe. And ultimately, when we ask a patient to participate, we have to give them information and encourage them to participate, but we also have to make sure that patients understand the risks and potential benefits involved in participating, and that they don't overestimate the benefits, and that we spend a lot of time listening to what questions the patients may have about the study, because there's a fine line sometimes between being enthusiastic and being coercive. So it's extremely important that patients ahead of time understand all the procedures involved, the risks and benefits involved in a study, so that they don't get themselves into something that they really can't commit to. The informed consent document usually is used to help the discussion and make sure that patients understand exactly what the point of the study is. There are certain concepts that come up in a lot of protocols. One is a placebo. And a placebo is an inactive product that may be very similar to a real drug or treatment, but is not known to have any effect on the condition. So sometimes patients don't realize that they're not all getting active treatment. Randomization is when a person is randomly assigned to one of two treatments in a group, and it's done usually in a blinded fashion to avoid bias or influence the outcome, and it's the best way to control for selection bias. And then single or double blinding really refers to whether or not the patient knows what the treatment assignments are and whether or not the researcher knows what the treatment assignments are. And most studies that are done are double blinded if possible. When the clinical trial is over, the data is analyzed to look at the differences between the groups. It's then sent for peer review to make sure that the process was sound, and ultimately published in a scientific journal. So people may ask, why should I take part in a clinical trial? And there are positives and negatives to participating. Some of the positives include to maybe get a new intervention that would not be normally available, to get an intervention that may possibly improve their health. A lot of studies cover the cost of an intervention, so that may be a way to get a certain treatment that they couldn't get otherwise. What we think is the most important reason is to help researchers answer questions about disease so that we can treat people better, and that the reason we're able to do so much better with so many diseases is because people participate and answer questions. And it's a good way for a patient to play an active role in their own health. However, it's important for anybody that's thinking about being part of a clinical trial to know that an intervention may not be better than the standard. In fact, it might even be worse. And that a new intervention may not have been well tested. It might have risks and side effects. That sometimes health insurance doesn't cover all of the costs of a trial. And that standard of care costs are often billed to people's insurance. That if you're in a randomized trial, you don't know what you're getting. Your physician doesn't often know, and you don't get to choose which intervention you receive. And probably the biggest deterrent for patients participating in clinical trials is that it takes a lot more time. Often there are a lot more visits, maybe more blood draws, maybe more procedures that need to be done, and that can make it difficult if a patient's working or has other obligations. So this is a little graph that shows a little bit of why we do clinical trials. This is a graph that says, our trials show that the new drug performs no better than placebo. Maybe we should just invest in placebos. And the point of this slide is really that we don't always know what we think we know. And that the reason we do research is because sometimes our clinical judgment is wrong. And sometimes everything can point in the right direction of a drug working, but until you actually test it, you don't really know whether or not there are benefits, and you really don't know what the harms are. So the National Cancer Institute has infrastructure in place to help with the conduct of clinical trials in an more objective way. Pharmaceutical companies and device companies are certainly interested in making sure that their products go to the FDA and become available to patients, and often they fund a large number of studies, but they're very much motivated to make sure that those studies are done in a way that they can approve the drug, which may not necessarily mean that the results are the best for the population. So the NCI has infrastructure in place that has changed over the past year pretty substantially, and it's the infrastructure for which many clinical trials are done. And the two groups that conduct clinical trials are the National Clinical Trials Network, or the NCTN, or the NCI Community Oncology Research Program, which is called the NCORP. So the NCI supports community-based research because the majority of cancer care is provided in community settings, and it gives access to large, diverse patient populations. It allows clinical trials to be done quicker, and it allows for the testing of feasibility in the practices where most patients are actually treated. So it's a way of increasing generalizability of the trials that we do. So you hear a lot about the NCTN, and the NCTN is really a group of the former, what we call cooperative groups, several of which have been merged together. that includes both the Children's Oncology Group as well as the Canadian Network groups, and the main adult groups, which are SWOG Alliance, NRG, and ACOG Akron. And each of these groups, they try to work together, but their function is to really set the goals for the future in terms of deciding which studies should be done and in which patient populations. And they work directly with the National Cancer Institute in terms of having steering committees that sort of implement and determine the priorities for research going forward so that the best studies can be done. They can be done quickly, and they can answer important questions so that they dictate the standard of care. And you may have heard a lot in the news about the fact that the clinical cooperative groups have been decimated in terms of funding, which is true to a certain extent, but it probably represents a shifting of allocations of money. According to the NCI, they're spending the exact same amount on clinical trials that they've always spent in 2014 compared to 2012 and 13, which is $151 million. However, they've shifted the allocation a little bit away from the cooperative groups, more towards what we call lead academic centers for participating, and ultimately thinking that they've made the system more efficient by reducing the number of cooperative groups and getting rid of a lot of overlapping infrastructure. So in addition to therapeutic studies is really the NCORP. And the NCORP research base is to look at the non-therapeutic studies, studies that focus on cancer prevention and control, screening, imaging in clinical trials. Their focus is to improve minority health and underserved accrual, and also it is the site where cancer care delivery research is done. And the NCORP is organized as in research bases, which, like the NCTN, set the research agenda, partnered with community sites, which also help inform the research agenda and make sure studies are done quickly and effectively. And ultimately, there's a lot of groups that work together to make sure these types of studies are done within the NCI. They work closely with the NCTN, as well as the Division of Cancer Control, Division of Cancer Prevention, Center to Reduce Healthcare Disparities, and the Division of Treatment and Diagnostics. So I'm going to talk just a little bit about some of the studies that we have open to give you a sense that, there are a lot of institutions, and most institutions offer different types of studies. In our program at Columbia, we have a lot of diverse interests, so we have studies that sort of span the spectrum of all the different kinds of studies that are out there. And some studies are done just in a single institution, and some studies are done throughout the country. So we have a large focus in prevention, and we have several studies that are currently open, one of which uses DHA, which is a form of omega-3 that's being used to prevent recurrences in breast cancer survivors. We have a study that has looked at vitamin D versus placebo in premenopausal women and at women at high risk for breast cancer to see whether or not that may show signs of improvement for breast cancer. And we've done really an educational intervention in first-degree female relatives of breast cancer survivors to see if targeting this group of high-risk patients improves factors that are known to affect both diagnosis and prevention of cancer. In terms of different types of treatment trials, we have a large number of trials where we give treatments before a patient gets their surgery. And one of the studies we're looking at is looking at the drug propranolol, which is a beta blocker, that a lot of those observational studies that I talked about earlier showed that patients that get beta blockers may actually have improvement in terms of reducing the risk of metastasizing. So because there can be a lot of bias, we then take that observational evidence and then try to do a clinical trial to see if we can determine why that may be the case. And this is looking at whether or not that drug affects the growth of a tumor. Similarly, there are other drugs, often many of the cardiovascular disease drugs, that have also shown to be beneficial for breast cancer patients in the observational setting. And we do a lot of studies between when a patient gets their initial biopsy and when they go for their surgery so that we can see how these different agents affect the tumor before and after we give it. We have a number of studies that are done in patients with early stage disease after they've already received their treatment, and this is called the adjuvant setting. And often these studies involve, unlike our own institutional studies that may involve 50 patients, these studies often involve 5,000 to 8,000 patients, and therefore they're done usually all over the country and sometimes even in other countries. And these are a list of several studies we have open right now. These kinds of studies open and close, but just to give you a sense of it, maybe a study is looking at one of 4 different types of chemotherapy regimens to help guide us in terms of that. We have studies looking at new drugs targeting the HER2 new receptor to see if the new ones are better than Herceptin. And we have studies in hormone receptor positive high-risk patients that ask whether, in addition to hormone therapy, a drug like everolimus can improve outcome. Then we move to patients with metastatic disease, and often this is an area where there are a lot of treatments approved, but we're often trying to find better and better treatments for patients with specific tumor types. And one of the areas that we've been interested in, triple-negative breast cancer, and we have a variety of different studies open. One that's open right now is evaluating erlotinib and metformin specifically in patients with triple-negative disease. We have been able to participate in clinical trials with industry and partnering with industry to give new drugs like palbociclib, which is the CDK4/6 inhibitor that has been in the news a lot, to see if that improves efficacy of hormonal therapies. And we have a whole variety of different types of studies in different phases that we can offer our patients when the standard treatments may not work anymore. And this gives us a lot of information in terms of which studies may be better to move forward and which drugs really are not beneficial at all. And then, as I said before, we're always trying to think of how to get people through their treatment better. So one of the things that we've been looking at are a variety of different CAM type approaches to reduce side effects. And we have a large study looking at acupuncture to treat joint pain that's caused by hormonal therapies. We're looking at electroacupuncture to see if it improves numbness during Taxol therapy, and a variety of different creams that we can give patients that might treat numbness that they may have had as a result of their chemotherapy. And then finally, we want to focus on survivors because so many of our patients do well, and we know that weight and energy balance and improved fitness can affect outcomes in cancer survivors. So we have a variety of different studies that look at ways of implementing exercise and diet so that they're more effective. So in terms of learning more about clinical trials, if people are interested, the first person to ask is an oncologist who may be familiar with clinical trial resources, websites, and what may be going on at their institution and other institutions. to focus on community resources in the American Cancer Society, to look at other local support groups that often have webinars such as this that can also provide a significant amount of information. On the internet is clinicaltrials.gov, and that lists all active clinical trials. Because of delays, sometimes there are studies that are on there that have already been closed, which can be frustrating, but it is a source to find out what's going on in the world, and then through friends and family. So that's really the end of this presentation, and I'm now open to answering questions.
Thank you, Dr. Hershman. I just want to check to see if my audio is working. Looks like it is. Okay, we have a couple of questions here. More and more trials are looking at drugs for specific mutations, pathways, or biomarkers. I'm working with NBCC and SHARE on the UMBRACA trial, which is looking for women with BRCA1 or 2 mutations and metastatic breast cancer. Unfortunately, many oncologists either don't know about the trials at other institutions or don't want to lose their patients. How can we get oncologists to refer patients to an appropriate trial at another institution?
Right. I mean, I think that is really unfortunate that sometimes that happens. Often, you know, it's less about not wanting to refer patients, but more about not knowing other studies exist. I think, you know, our obligation is obviously to do what's best for the patient, and we try to work together with a lot of the other institutions in New York City so that we can work collaboratively. We send patients, they go on a study, then they, if they're off that study, then they send the patient back to us, and that you don't necessarily have to lose contact with the patient or your relationship with the patient over time. And you know, by doing that, you can, as a researcher, if you put patients on other people's studies, then hopefully they'll put patients on your study, and then you'll all get your studies done much faster in terms of coming up with the right answer. So I think institutions that are offering clinical trials need to reassure the referring physicians that as soon as the patients completed the clinical trial, that they'll go back to the original oncologist for their care.
Great. From my experience, one of the largest barriers to clinical trial participation is doctors don't bring up clinical trial options to the newly diagnosed. What can we do to help standard of care get to where every patient is screened for trial eligibility at first diagnosis and at each recurrence?
Well, there are actually fewer, you know, it's impossible to have a clinical trial that covers every type of patient at every stage of the disease. And, you know, with shrinking resources, often the patients, there are only clinical trials for patients at the highest risk. So often people are being screened for studies and they don't even know it. So, you know, it can be quite difficult to screen for studies that that you don't know about. So it's ultimately important for physicians to try to stay on top of things as much as possible. But it's also important for patients to advocate for themselves and ask if there's any study they could potentially be part of.
Right. You mentioned the importance of having different races and ethnicities in clinical trials. Why is this so important?
Well, we know that there can be differences based on genetic differences and other factors that may contribute to differences in disease outcome. that may affect a patient's response to a treatment. And not every population has the same response. And so the more diversity we have in our clinical trials, the more we're able to really determine if what's true for all of our Caucasian patients is also true for all of our Hispanic patients. And we've seen in clinical trials, for example, in colorectal cancer, where Asian patients have a much higher prevalence of a certain mutation that affects the way they metabolize drugs. And that makes them more susceptible to getting certain toxicities. So that's how we learn these things, is by having diversity. And it also helps us down the line sort of retrospectively understand why there may be ethnic and racial differences in outcome.
Interesting. This question is about metformin. I've heard a lot about this drug. Can you talk about any early results?
Well, there is a lot of interest in metformin because metformin lowers insulin levels. And there is substantial preclinical data that suggests that higher insulin levels are associated with worse outcome, that higher insulin is associated with increased risk of developing breast cancer, that breast cancer cell lines that are in an environment that is low in insulin don't grow. And then there's data that shows that patients that have breast cancer that are treated with metformin seem to have further diabetes, seem to have better outcome than breast cancer patients that don't have diabetes or are treated with other diabetic agents. Mm-hmm. So all of that data together has piqued a lot of interest. And in addition, there's some evidence that it's synergistic with other pathways, such as the mTOR pathway, which is something that regulates a lot of breast cancer. So based on all of this, there have been, in the metastatic setting, studies that have included metformin with other drugs to try to understand the biology of cancer. And none of those kinds of studies are definitive. They're more hypothesis generating, in that they can show that, you know, if you give metformin to a patient before they go for their surgery, it affects the proliferation of the cancer cells, i.e. how well they're dividing. So based on all of that, the NCI and the NCI of Canada has done in breast cancer a large adjuvant trial where they randomized patients to getting metformin or placebo after they completed their chemotherapy. And ultimately that will help provide the definitive evidence of whether or not it's beneficial.
Okay. And the trial that you were talking about with metformin about triple-negative breast cancer, is it triple-negative early stage or metastatic breast cancer?
No, that's for metastatic patients. And that's based on a lot of data in certain types of triple-negative breast cancer that suggests that there may be synergy with ones that are driven by EGFR, and that's why metformin is combined with an EGFR inhibitor.
Okay. And you mentioned the BFIT trial. Can you talk a little bit about what the educational intervention is?
The educational intervention is really aimed, you know, it sort of follows the model of cardiovascular disease, whereas if you have a first-degree relative, likely you're at high risk too. So maybe a good way of targeting for prevention is to target first-degree relatives of breast cancer patients, and a lot of it is really looking at whether or not you can change screening behaviors and lifestyle interventions, lifestyle approaches to cancer preventions through education. So really teaching people about what their risk is, the importance of screening, the importance of weight management and exercise, and whether or not that patient may be interested in genetic testing.
Okay, so if we see a trial for vitamin D or DHA, for example, and the evidence is showing that the results may be good, should we ask our doctors to put us on these drugs even if we don't qualify for this study? So they're not talking about chemo drugs, they're talking about, something
Right.
over the counter like vitamin D.
So I have been the principal investigator on 2 supplement studies, one of which showed that the supplement patients that were assigned to the supplement did worse, and one of which showed that the supplement was no better than placebo. And these are agents that are very commonly taken by people because they can get it over the counter. So in this country, a lot of people spend a lot of money on supplements, and without knowing whether or not they work, they could be causing harm. So for something like vitamin D, there's ample evidence that, it's probably not going to cause harm as long as people's levels don't go up. But if you take the agent without participating, then it becomes hard to find the right answer. So usually, nobody can stop anybody from just going out and taking something that's available over the counter, but there may be harms to it. And every prevention study that's been done to date has shown that the supplement actually does harm. The very first study in lung cancer, where they looked at beta-carotene, patients assigned to beta-carotene had an increased risk of lung cancer. The SELECT trial for prostate cancer, where patients were randomly assigned to vitamin E and selenium, patients who got vitamin E had a higher risk of prostate cancer. So one should not assume that just because something's available over the counter that it's safe. So that's, I guess, my answer to that.
And I guess sort of a follow-up question, are many other researchers doing studies on supplements?
No. Doing studies on supplements can be very difficult because, as you said, a lot of people are already taking it. And we did a very large study on omega-3 fatty acids, and the number one reason why it was hard to accrue initially is because people already take it. And so they can be difficult to do from that standpoint, and they also involve grant funding, unlike pharmaceutical companies, where the pharmaceutical company is very eager to get their drug approved and pays for the study. In order to do a study of supplements, you have to get a grant.
Right. And there's been a lot of news lately about vitamin D and breast cancer. Can you just talk about that briefly?
Yeah, so this sort of falls into the same line where there's a plethora of observational data, some of which shows an association with vitamin D and risk of breast cancer, some of which shows that there's an association with vitamin D in patients with breast cancer, that it affects outcome, and some of which don't show those findings. They show that there's no association. Even if it's true that there's an association with low vitamin D at diagnosis and worse outcome, and even if there's an association with low vitamin D and increased risk of developing breast cancer, that does not necessarily mean that taking vitamin D will change it. Vitamin D level may be an innocent bystander, and it really is something else. So there are a lot of ongoing studies looking at vitamin D to try to get a better sense of what supplements actually do to breast tissue and breast density.
Mm-hmm. So someone's saying that historically minorities are underrepresented in clinical trials. Can you talk to ways we can effectively reach out to this population with the goal of increasing clinical trial participation?
Right. So that's an excellent question.
Yes.
There's a great concern about that issue. The NCI funds certain centers that have higher minority representation in the population to have programs to increase minority accrual. These are called minority underserved NCORP sites, where there's extra funding to try to help enhance minority accrual. Each of the research bases has a mission to try to work with the community to increase awareness about clinical trials, to enhance minority accrual. Some of the disparities in accrual come from socioeconomic factors. As I said before, clinical trials take a lot of time, and one of the, so as a result, patients that can't miss work or have, or socioeconomically disadvantaged sometimes have a harder time participating even if they want to. And then it can also be the result of the kinds of institutions that do studies and access to care. So, you have to hope that with increased awareness, increased access, and increased programs, educational programs and clinical trials, that ultimately that will have an effect on having a more diverse patient population for clinical trials.
Great. Thank you. Someone just says that another resource to find out about clinical trials is breastcancertrials.org. It has the same information right from clinicaltrials.gov, but it's a little more readable and
That's
searchable.
Great.
Yeah. So thank you so much, Dr. Hershman, for a great presentation, and thank you all for participating. If you wouldn't mind, take a little time to complete our short survey and let us know how we're doing. And for upcoming programs, visit us at sharecancersport.org. Thank you so much.